I am Martha Kane. I'm the Clinical Director for the Center for Addiction Medicine, Clinical Director for the Substance Use Disorders Initiative, and the Clinical Director for Outpatient Psychiatry at Mass General Hospital. This turns out to be one of the most complex, difficult situations that we face in the mental health or substance use world, and in fact, really in medicine altogether, this interaction between mental health disorder and substance use disorder. It is unfortunately extremely common. It's more common than not. Someone with a substance use disorder, I'm going to talk to you a little bit about percentages, but they are extremely high for comorbid mental health disorder, and the reverse is true to a slightly lesser degree. What we do know is if you've got both, the course is more chronic, the outcomes are worse or more complicated, and that the symptoms of the two disorders interact in a negative way to create much more difficulties. So when someone suffers from both a mental health disorder and a substance use disorder, it can happen in a number of ways. One could have two different disorders that don't really interact very much, but quite frequently what actually happens is the two disorders interact and make each disorder more difficult to manage. So the substance use disorder becomes more pronounced while people are trying to manage a bad depression. At least they feel a little better when they've been drinking alcohol for a little while. It lifts the depressive mood. So they can actually potentiate and make each other quite a bit worse. Substance use disorder increases the risk of mood disorder starting. So I'm fine. I start using alcohol. I don't realize it's got the connection to depression. I start to develop a depression. I think I'm depressed. I can make the connection. It doesn't make any sense to me that it's because of. And as a treater, when I say to people, yes, so here's the bad news. You may be depressed, but that alcohol use is really impacting it. As a patient, as a person with this, I don't experience it that way, and I think you're nuts, because what happens? When I drink, I feel better for an hour or two. But that's the association that I make. So it doesn't make any sense to me. You drink again, it becomes kind of a vicious cycle. You feel terrible, you want more alcohol, you feel a little better after you drink again, you go back to drinking, and at the end of all of it, you have a very serious depression compounded by a very serious alcohol use problem. The distinction has been for many years that there are two separate divisions. One is the Department of Public Health, charged with managing all substance use disorders, and one is the Department of Mental Health, charged with managing all depression and all other mental health disorders. And so even at the structural level at the government, there are two distinct silos. The problem is their funding streams are different, their approaches are different, and the result is that people who are primarily trained in mental health are not actually trained as well in the substance use disorder protocol, and vice versa. We don't experience these two different disorders separately. It's an integrated problem. It's one leads to the other, leads back to the one. For us, there's not a lot of separation. When the treatment system treats it as if the depression is separate from the alcohol use, you go one place to get your depression treatment, another place to get your alcohol treatment. In essence, we're asking people to sort of carve these two things apart. They don't exist apart. They exist in a single integrated whole. So you need to be able to go to a provider who both understands depression and understands alcohol use disorder, or maybe two providers in the same setting who talk to each other, so that we can actually treat it as a single entity, as a thing that is an integration of two separate disorders. In that way, people can actually potentially start to benefit and recover from care. So for people who have a mental health disorder who begin to develop a substance use disorder, there are likely several things that could be done to try to help prevent that. The first and foremost is that the people who are taking care of the mental health disorder with the patient need to continue to screen and recognize vulnerability. There are different degrees of vulnerability depending on the type of mental health disorder, and those who are treating the mental health disorder need to be acutely aware of just how much risk there is for the onset of a substance use disorder. Watch for the red flags, watch for the signs and symptoms that a substance use disorder is beginning. Be free and open to ask about that and to help your patient acknowledge that and start to work on it as an event that has occurred, not as a shameful thing or as something to be avoided, but something to actually be treated. The way we understand things now is that substance use disorders live on a continuum from minor to, oh my goodness, so severe, and everything in between. And people move up and down that continuum over the course of their lifetimes. They don't ever really get off, but they don't stay. It's not a discrete thing. You're not either a substance abuser or you have substance dependence. Essentially, it ranges from very mild to very severe, and you can be anywhere in between, and that can change at any, for whatever reason. If you have mental health disorders and things like that are treated or untreated, you tend to be a little bit more on the severe end of this. You expect, because you can't really get off that continuum, that there will be symptoms that get worse and get better, and then get worse again and get better, and that relapse now takes on a whole other meaning. It's not, oh my goodness, I failed, right? Now it's, oh dear, symptoms are back, need to have a new treatment plan. Got to figure out what else to do. And treatment really shouldn't ever stop. It may be every person owns their own treatment. So whatever you need to keep yourself well is your job to get done. But typically you're going to stay in some kind of connective relationship. Maybe it's self-help and that's good enough, or maybe you're actually going to need therapy in and off and on, depending, or maybe you need to go back to detox. Whatever it is, you're going to more or less stay in contact with some kind of supportive work or treatment over time. Treatment varies along a number of dimensions. One of them is the substance being used. If someone is using a substance that's likely to cause their death imminently, like opioids, versus using a small amount of alcohol or using cannabis, which eventually will cause harm, but the timeline is much slower, we're going to approach it quite differently. So with opioid use disorder, pretty much regardless of the mental health disorder, we're going to recommend the immediate use of medications to try to help people stay alive, like Suboxone or Methadone. For something like cannabis use disorder, which is slow, develops over time, we're going to gradually want to work with the patient around alternatives for the reasons that they're using the cannabis. Many people begin using cannabis either recreationally or they use it for sleep. If they start to lose control of that, then we're going to need to aggressively treat it. But at the beginning, we might treat that as a small matter. So depending on the substance, depending on the context of the mental health disorder, we absolutely approach these things differently. Where could integrated treatment occur? Primary care doctors, right? Everybody's got one. They don't fire you for messing up or relapsing or having symptoms again. In fact, when you disappear on them, they worry. They try to find you. But how about emergency rooms? My goodness, what an opportunity. What an opportunity. You're there, you're pretty ready to get some help. If we had the right help to give you right then, what an opportunity. Inpatient hospitals. We could think about patient-centered medical homes, and that's a sort of a population health management approach that's really rooted in primary care, but it's primary care on steroids with behavioral health and a bunch of other things that really help to do sort of one-stop shop, the primary care location, patient-centered medical home. Peer-based recovery centers. And they are some of the most valuable resources. They're run by people in recovery. They have tons of services and resources. They exist both in the mental health world and in the addiction world. Any mental health treatment, any one of them that exists right now could become integrated. It's not that hard. And ditto, any substance use disorder program could integrate care right now, as long as we kind of climb up out of our box and look outside. So here at the Mass General Hospital several years ago, we were offered the opportunity to completely restructure the way substance use disorders are cared for throughout our system, inpatient, emergency room, outpatient, and everything we could think about in between. As a result of that, we now have an inpatient team that works directly at the bedside with patients who are having substance use disorder issues. We have services available now through our emergency room. We have teams in almost all of our primary care practices who are dedicated specifically to taking care of patients with substance use disorder, as well as a brand new clinic for patients who are parenting or pregnant, their partners and their children through the first 2 years of the baby's life. So in a number of different venues, we've tried to bring in substance use expertise to the program and to integrate that with medical care, psychiatric care, nursing care, and any sort of care services that are available within that venue. When a person comes into the inpatient setting and they receive services at the bedside, they are 25% less likely to have another readmission for the same issue. So we're able to help people come in, get some care while they're here in the inpatient setting, and then not have to come back as often as was happening before. In addition, we've added a number of recovery coaches, peers in recovery throughout the system who help with this. When someone has one of these peers and they are on medicine for addiction, we notice that they are much more likely to stay on medicine for addiction for long enough to start to really get well. So something along the order of 92% of people who have a peer supporting them and are on medicine stay on medicine. We have a small bridge clinic, it's called. It's essentially a clinic that allows patients to walk in or drop in, so very low bar, very easy access. It's really easy to get addiction care in that clinic. We've recently added mental health care there as well, so there's now medical care, mental health care, and lots of peer support there. They're bursting at the seams and able to really help people stabilize. We thought that they would need 3 to 6 months to kind of stabilize and be able to move on to more traditional types of care in the community. What happens is most people move on within 2 months. So a bit of stabilization, a bit of getting on their feet, they can move to their primary care office, a community-based treatment provider, or some other place where they can then get long-term care. We're very excited about that. I also think there are a number of payer problems that need to get sorted out. So in my future world, the notion of how does this get paid for gets sorted by recognizing that when we take care of it, people are well, they don't need as much high level and more acute types of care. So we could lower healthcare costs a bit if we took care of this in a more integrated and effective way right from the beginning. And I would love to see that we got past our notions of stigma, judgment on these people. What they have is a disease, it's like any other. Unfortunately, it's a sort of an integrated piece between their genes and their experiences in life, and the result is this difficult disorder. And for all of us to understand that, be ready to treat it more effectively and to drop and get rid of the judgment and the punishment, which ultimately makes them sicker, makes healthcare costs higher, and doesn't move anything forward. We're stuck when we do that. So I'd love to see stigma dropped and people to recognize this as a disorder that needs treatment.
Thank you for watching this video, and we would love to share more with you. So please subscribe to this YouTube channel. For more information about all of our trainings, please visit the link below.